So I'm honored to invite the next speaker. Is actually local to Montreal. Ron Postuma is going to talk about GBA and RBD. Thank you.
Great. Do I have to do anything to make this work? I have to find myself. There we go. And open that. And do that. Oh, I can do it. Hi, everyone. Good afternoon, and welcome to Montreal. Sorry about the weather yesterday. That was weird. It's not normally cold at all. It's usually very hot, but today is gorgeous, and thanks for staying for it. So I'm being asked to talk about GBA. I'm very aware that the audience is quite diverse in terms of expertise, and so we have all the way from basic scientists to clinicians. So I'm going to assume nothing in terms of expertise. And I want to talk first a little bit, give you a sense of what's going on in the field of prodromal Parkinson's in general, okay? There really have been major changes in the last 10 years. Then we'll talk about RBD. I'm going to make the case that it's so strong it basically is Parkinson's disease. And only after that will we start coming back to GBA and then talking about how we integrate all this in terms of neuroprotective trials. We've come a long way since the 1970s when Parkinson's disease was this, a disease of the substantia pars nigra compacta, where you lose this sort of black signal, and that's what Parkinson's is dopaminergic disease. And we in fact recognize now that everything on this list is all a common manifestation of Parkinson's disease, in fact experienced collectively by just about everybody, and individually by sort of 30 to 50% of people will get every single one of these on the list at some point in the course of the disease. And these without question represent the major unmet need in the field of Parkinson's disease. And we're starting to understand a little bit in terms of the pathological basis of this. And so these, of course, are the famous staging models, the original one by Brack, but there have been many others. And the core principle here is based on synuclein staging, where synuclein is deposited in the brain. The idea is that Parkinson's probably starts in the olfactory nucleus, dorsal motor nucleus of the vagus, and perhaps in the peripheral nervous system, and does this semi-geographic, prion-like perhaps march around the brainstem, only affecting the substantia nigra, the major area by which you define disease, at stage 3, and because you're because of redundancy in the system, you don't show up until it's all over your cortex in stage 4, 5, and 6. This is the original Brack model. There are other models which I think probably explain a little bit of the diversity of synucleinopathy a bit better. For example, this is the Mayo Clinic model, which posits that everything starts in the olfactory bulb, but then the synuclein can do two paths. One is a conventional sort of Brack model pathway, going down into the brainstem, coming up, and getting the cortex later. The other way is to go around to the limbic system and then get the cortex, and of course that would correspond to what dementia with Lewy bodies is. Regardless of the details, I think the concept is very clear, and it has been replicated again and again in about 90% of Parkinson's patients, and has a lot of implications. It means that Parkinson's disease and dementia with Lewy bodies are not just defined by their motor cognitive symptoms, and most importantly for this talk is that all of these non-motor things, those things that I showed you in the list, may in fact be the earliest markers of Parkinson's disease. And this has been a massive field, and I don't have time to show you all of these markers. I'm going to cover a few of the highlights, but everything on this list is essentially, we know, is a predictor, if you will, or better perhaps characterized as an identifier of the earliest stages of Parkinson's disease. I'll just give you a few of the major highlights to give you a sense of what's going on besides REM-sleep behavior disorder. So this is the one that I think was probably the first to be the major, well-known one, and I think is still one of the top two predictors of Parkinson's disease. There are now more than 11 prospective population-based studies demonstrating that if you lose your sense of smell, you have a 5-fold increased risk of developing Parkinson's disease in the future. And this is quite high relative to most of the clinical markers. So a lot of the other ones have a 2-fold risk. This is a 5-fold risk. And what does it predict? Dementia as well. It does predict Alzheimer's disease, but it looks a little different in Alzheimer's. They smell it, but can't identify it. And the DLB and the Parkinson patients don't smell a thing. You hold these things up, these scratch and sniffs or these sniffing tests, and they have no idea that they're supposed to smell anything at all in the majority of cases. The lead time is very long. I'll show you that in a minute. And what's really attractive about olfaction is how easy it is to scale this up. You could easily do this in the general population with, mailed scratch and sniff tests, or these which are commonly used in Europe, which cost $1,000, but you can just run patient after patient after patient. This is one you may be less aware of because it's relatively new. So this is neurogenic orthostatic hypotension. So this is not just your blood pressure drops when you stand up, but in a lab it's shown to be neurologic in origin. And this is one of the first studies which documented this. The real only years you should pay attention to are the first 4 years, which are directly observed. But this is a relatively small study of 74 patients. They followed them up at 4 years, but 34% of people with this pure neurogenic orthostatic hypertension, nothing else wrong with them, got a neurodegenerative disease. And what did they get? They only got one disease if you're a lumper. 13 got dementia with Lewy bodies. We should never forget that DLB is exactly what we're talking about when we're talking about prodromal Parkinson's. I use the word Parkinson's. I come from Parkinson's, but I'm talking about DLB at the same time. And Parkinson's disease and MSA, which of course are synucleinopathies. And that's the only disease that's ever been shown to emerge from primary autonomic failure in this cohort, and there's a more recent one that was published more recently. We should remember that nothing starts suddenly, and of course everybody would know that a neurodegenerative disease would emerge gradually over time, but we've never really had the opportunity to watch a person get this. This is one example. This is a very large study in the Rotterdam general population where there were just nurses who were doing motor exams. And I didn't show you here, but motor slowing was evident 6 years before patients got Parkinson's disease, and I know this prospectively, so the curve started to diverge 6 years before compared to age-matched controls. But there's all kinds of other things that you see. For example, people ask about their ability to do independent activities of daily living are going down about 8 years before disease, and traveling, actually it's not even 5, it's probably about 7 years. 7 years before you get Parkinson's, you stop going on vacation. And so that's really quite interesting, isn't it? Something's going on with the personality or anxiety or something. This is the clinical, which have been way ahead of the field. The biomarkers are catching up, but they're pretty impressive now. Of course, we know that dopaminergic imaging is important in Parkinson's disease, and certainly it does predict the classic Parkinson's disease. It really does break down, I will say, in dementia with Lewy bodies. It does not work nearly as well as predicting DLB. I've seen a few negative DAT scans in confirmed synucleinopathy patients with biopsies. There are PET metabolic patterns that you can see. There's something called a Parkinson's disease-related pattern, which has to do with glucose utilization. And this is actually being demonstrated in many labs now to be a very strong identifier of early stages of Parkinson's disease. There's a million of these different patterns out there. MRI has been difficult to standardize, but it's getting there. So for example, if you can see this black, white, black signal here, this white is Niger zone 1 of the substantia niger, and it gets lost in Parkinson's disease, and it kind of looks like a bit of a smear, and sometimes you can't see it at all. And in fact, this has been established to be present in prodromal Parkinson's as well. And there are many others. Neuromelanin is extremely promising, as is DTI, resting state, which is harder to analyze. Synuclein scans, the bottom line is they don't really exist yet in terms of predicting Parkinson's. There might be an MSA hit, but it's a tough problem to handle. And this is one that you maybe have not heard of. In fact, you lose sympathetic innervation to your heart. This is a heart of an MSA patient on an MIBG scintigraphy trace, and this is the Parkinson's who has no visible heart whatsoever on this trace. And in fact, this is present in 80 to 90% of Parkinson's patients. So that's a really interesting marker, and it's very good prodromal marker as well. All right, this is what I was asked to talk to you about. This gentleman is having a dream. He's out for a walk with his wife, and as he's walking for his wife, he's set upon by a group of people who are trying to steal their wallet. And in his dream, he's defending his wife and himself from the attackers. Now, if you had that dream, you would not be able to do that. You might moan, you might twitch, but you would be paralyzed. You would be unable to do this. 1% of the population is capable of making these movements, and they have what's called REM-seq behavior disorder. So it is not rare. 1% of the population has this disorder. The people who present to doctors' offices tend to be men in the ages of 50 to 70. This has a lot to do with simple sex biases and mortality patterns, who gets woken up, and what kind of dreams people have. In fact, when you look carefully, the male-female difference is minimal, if present at all, in reality when you screen. Most people don't think of going to a doctor, but they're aware that they have it if you ask them. And so there are ways to screen in the population. We've had success with screening for this. It's very, very easy to find these patients if you just ask them if they act out their dreams at night. So you can recruit massive numbers of these people very, very quickly if you so wished. The diagnosis is somewhat difficult because the reliable diagnosis requires an overnight sleep study, because not every active dream is REM sleep behavior disorder. So sleepwalking and sleep talking, which are extraordinarily common in the general population, associated with nothing at all, are a different phenomenon and have nothing to do with RBD. And apnea can be a mimic and also a coincidental common comorbidity. And so what you do is you do this polysomnogram. This is a patient who's in REM sleep right now. And what you can see is that normally it should look kind of like this. This is the chin EMG. It should be a little flat line like this when people go into REM sleep because they're paralyzed. This gentleman is not paralyzed at all. He doesn't lose any tone. And then, of course, he starts dreaming and he acts things out. Many sleep centers do not do this very well, the diagnosis, and so it's very commonly missed or not accurately diagnosed. And there are real barriers to generalization of this. And so an emerging field of home diagnostics is happening. One very simple is to just do a proper polysomnogram with EEG at home, which at least saves the patient from having to be sleeping in a lab and have a technician on site. But there are now, it looks like we can do pretty good jobs, sort of 90% accuracy with things like actigraphy, just measuring how much you move at night, and applied with deep learning. And so if we wanted to scale these up in the future, we're going to have to do things like this, and we're working on that. So what are the associations with REM sleep behavior disorder? So it's not only synucleinopathies. It can be seen in brainstem strokes, MS, brainstem plaques. It has to do with the anatomy of, you just have to hit the REM atonia center. We're starting to see some rare autoimmune encephalitis, and in late other neurodegenerative diseases like PSP and the like, you can see it. But it's seen very commonly in Parkinson's disease. Parkinson's disease, about 25% at the time they're diagnosed, cross-sectionally 50%, ever in the course it's at least 75%. So this is something that often builds up with time. Dementia with Lewy bodies is even more common, over 50% of people at diagnosis, and cross-sectionally even at 75%. And if you live long enough, you will get this. And multiple system atrophy, both the Parkinson's subtype and the cerebellar subtype, have it in a large majority. And again, what do these share? These are the neurodegenerative synucleinopathies. I want to do a bit of a sideline because it comes up with what we just talked about. So I've been following these patients for years, and then I watch these RBD patients get Parkinson's disease, but I'm also a Parkinson clinic, and I was in the Parkinson clinic just now this morning. And I remember thinking, you people at disease onset year 1 look worse than many of my patients who I've been following for some years. And when we look deep down at this, these are the sort of the first studies to have shown this, what's most dramatic is autonomic dysfunction. For example, Parkinson's patients without REM sleep behavior disorder do not drop their blood pressure when they stand up, but Parkinson patients who do drop their blood pressure by a mean of 25 millimeters of mercury, a very, very dramatic difference. The other difference that became very obvious was cognitive impairment. This is a sample of idiopathic RBD patients. In other words, they don't have anything else yet. 50% have MCI. Parkinson patients with REM sleep behavior disorder, 75% had MCI, but those without REM sleep behavior disorder had no different prevalence than the controls. And if we followed these same patients up in the future, in fact, the risk of developing dementia was about 50% in this group, and it was actually 0% for the first 5 years in those without REM sleep behavior disorder. And this is now being seen in over 50 studies. This is replicated over and over and over again. REM sleep behavior disorder is a risk factor for a certain type of disease. And so just in summary, what they are, motor severity is not that different. It's a little bit worse. I think mostly gait, they get a little less tremor. What's very clear is an autonomic loss. Other non-motor, most things we don't find, some a little bit of olfaction loss, more in those with REM sleep behavior disorder, and cognition, hallucinations, depression, and dementia. And of course, what does that sound like? Of course, that sounds, I haven't said the words GBA yet, but this is the GBA phenotype of Parkinson's disease. And so the REM sleep behavior disorder patients look like GBA Parkinson's disease. In fact, if you do an autopsy on a Parkinson's patient and they have REM sleep behavior disorder, you will see more synuclein in their brain than if they don't. It's a more synuclein-driven pathophysiology, so maybe a lysosomal sort of pathophysiology. It's not just Parkinson's disease. Within DLB, dementia with Lewy bodies, RBD correlates with Parkinsonism, hallucinations, and fluctuations, which are the hallmarks of DLB and indicate synucleinopathy. And in fact, it's associated with a higher rate of mortality as well. Okay. So this is why mostly why I'm talking to you. It's this astonishing predictive power of REM-sleep behavior disorder. So this is 1,280 patients for the REM-sleep behavior disorder study group, and this is a classic Kaplan-Meier survival curve. These are patients who have REM-sleep behavior disorder and nothing else, and every time it drops, another person has developed a neurodegenerative disease. And what you can see is it's about 6 to 7% per year in this observational study. It's higher if you look closely. This is clinical observation studies. It's probably about 8 to 10%. But what's somewhat depressing is that the curve just keeps going down, and at 15 years, essentially everybody has developed a neurodegenerative disease. What do? They get one disease. They get Parkinsonism, they get dementia with Lewy bodies. Most of the Parkinsonism is Parkinson's disease, about 5% are multiple system atrophy. So the bottom line is just about everyone with REM-sleep behavior disorder already has a neurodegenerative synucleinopathy. Thinking differently, we've always thought about these as this is predicting Parkinson's disease, but it's not predicting Parkinson's disease. It's identifying Parkinson's disease. So many of you might have been aware of the two very highly publicized and somewhat controversial, I think, staging classification systems of Parkinson's that were published in the Lancet Neurology. And the core idea here was to change our thinking about Parkinson's because of some massive advances into thinking of it as a clinical syndrome and trying to define it biologically as a biological entity to which you can apply clinical diagnostic criteria. There are two of these. One is the synergy system. Full disclosure, I was involved in this one. And the other one abandons the term Parkinson's altogether and goes with a neurosynuclein disease. So both of these are actually relatively similar because they share things that were talked about a little bit earlier. Synucleinopathy, okay, can be defined as presence, and the synergy system can be defined as presence of a positive biopsy. And it turns out that 80% of idiopathic RBD patients, 80% if you do a single punch biopsy, have a positive synuclein biopsy compared to 0%, maximum 5% of controls. And if you talk about the CSF seeding assays, which were mentioned earlier, remember they're present in about 90% of Parkinson's, 90% of DLB, and 90% of REM-sleep behavior disorder patients. So REM-sleep behavior disorder patients meet these criteria right off the bat. The second aspect of this is and here's where the two systems diverge a little bit. The synergy talks about neurodegeneration in general, whereas the NSD requires only dopamine to stage further, in other words, a DAT scan. So here they differ a little bit, but regardless, most idiopathic RBD patients are normal on their DAT scan, which is what you would predict if you know about the staging systems of Parkinson's disease. But this MIBG scintigraphy that I mentioned, 80 to 90% of idiopathic RBD patients already have an abnormal scintigraphy. In other words, these patients are S positive, N positive 80% of the time already. They have Parkinson's disease. When you think that they already have Parkinson's disease, you can do some very interesting things by following these patients over time. So for the last 21 years, I've been watching patients with idiopathic RBD and then just doing the same exam every year. And then what you can do is you can look at them at the time of their phenoconversion and trace backwards to see what happened. And so this is, just to orient you here, this is a real data scale of idiopathic REM-sleep behavior disorder. And the y-axis is, this is that particular marker as bad as it practically gets, okay? Not the maximum possible score, but as bad as one practically sees. And these are age-matched control values, and this is time. And this is the phenoconversion time equals 0. So this is the less important part. What we've never been able to do before is watch this. And so when you directly observe these patients, and you do have to do a bit of extrapolation, but not much, you can see that the first thing that goes in idiopathic RBD patients is hyposmia. They lose their sense of smell. Followed around that time by REM atonia loss, which of course is RBD. You got to be a bit careful about that one because they all have RBD. Followed about 10 to 15 years before disease by autonomic dysfunction. And then finally 5 years before disease, either motor or cognitive or both. And they do this very exponential takeoff, very, very fast. So these are slow, and this is very, very fast. Hyposmia, REM-sleep behavior disorder, autonomic dysfunction, followed by motor and cognitive is exactly what these things would have predicted. So we're actually seeing in clinical, real life, these pathological models starting to become illustrated. Okay, I still haven't said the word GBA except for once, okay? But I think that's, I think we've hit some highlights there. What do we know about the genetics of REM sleep behavior disorder in general? This is not my slide. This is Ziv's slide. Ziv has done basically everything on this. He says he hasn't, but he has. This is the GWAS that was published, I guess, a couple of years ago now in Nature Communications. And this was the first GWAS. This is a 1,000-something patient. There's now 3,000. And before we go to the hits, I want to just mention a few things that are absent from their RBD GWAS. We do not see LRRK2. And in fact, LRRK2 patients rarely get REM sleep behavior disorder. Rarely is uncommonly get REM sleep behavior disorder. We don't see the mitochondrial genes. Now, you wouldn't expect those on a GWAS, but Parkin, PINK1, GJ1 patients don't really get REM sleep behavior disorder. We didn't see the inflammatory genes here, although they are seen certainly in the PDGWASs, and we don't see ApoE4 either, which is, of course, an extremely important risk factor for dementia with Lewy bodies. But we do see the hits. Nope. These are the hits, okay? Synuclein, obviously. GBA, okay, very, very obvious right here. And then we have TMM175, SCARB2, and INPSFF, okay? If you look at the mechanisms of this and some of the pathway analysis that came out with the Nature Communications paper, you see something interesting. So you see GBA, you see synuclein, which you heard about yesterday, interacts with GBA, SCARB2, which transports GBA to the lysosome, TMM175, modifier, etc. Everything that hit on this GWAS, you can make a case that it goes together with GBA. We've actually been studying GBA, and again, we send all our samples to Ziv, who's been analyzing them, and this is our first personal experience with this. This is 102 patients with REM sleep behavior disorder. Our numbers are not big when you're dealing with RBD in a single center. But we did see a couple of really interesting things. Okay, so first of all, we have a lot of GBA. So 13% of our RBD population, this is again idiopathic RBD, they haven't gotten anything else yet, have GBA, which is about double what you see in general Parkinson's disease. And we think that there might be a bit of effects of our local population. There's, for example, a couple of French-Canadian mutations. But if you look at the clinical characteristics, and we don't have tons of power, but we do pretty thorough clinical examinations on all of these patients, on all of these other predictive markers. And if you compare the non-carriers to carriers, we don't see any significant effects, but we didn't see any ghost of any difference either. Our GBA patients look absolutely identical to our non-GBA patients. And when you sort of think about that, the RBD patients look like the GBAs, and the GBA RBDs look like the G non-RBDs. We're really looking at a phenotype of disease. But when you follow these patients over time, and particularly when you adjust for age, we actually saw an almost tripling of the phenoconversion rate in our cohort. If you have a GBA mutation, it looks like the same disease, but it goes faster. This is the multi-center confirmation. Okay, this is now a very, very large study. This is, again, not me, this is Lynn Crone. So when we go to the multiple centers, we do see a little bit lower, but it's still very high. It's 9.5% and versus 4.1% of controls. And if you look at the details of the table, the one that leaps out the most is the E326K, and there's the T369M. Those are the commonest ones that we see. And we do see some confirmation, less dramatic than we saw in our single center, less consistently followed, I must say, in the multi-center things. We do see that 53% of the GBA positives phenoconverted over observation versus 36%. And there may be some suggestion that the severe cases go faster than the mild and the moderate mutations, not cases, mutations. Okay. I finally want to finish up a little bit with what we're going to do with this all. Okay? So we're all here because we want to do something about these diseases. This is intellectually fun, but that's not what we're doing. And it's very obvious to everyone in this room that when we develop a neuroprotective therapy for Parkinson's, it's unlikely that it's going to stop it completely in its tracks. We might get a bit of restoration. What we're probably going to get is slowing. And so if you apply any neuroprotective therapy in mid-stage disease, yes, that will be useful. That will slow down dementia and wheelchair-bound, etc. But if you can apply that same therapy here, of course, you can prevent them from ever having any clinical expression of disease. It has been obvious to everybody that you can't imagine a better group for a neuroprotective trial against prodromal Parkinson's, or against Parkinson's in general, I would say, than an RBD patient. Why? Because you have 10 years to work with. the average interval between a person developing RBD and developing that full manifestation of disease is 13 years when you ask them about their symptoms. An amazing window of opportunity to intervene. They're so high risk because they all have the disease already, and very important, they're untreated. So the biggest problem in a Parkinson's trial is we keep making our patients better with levodopa. And the difficulty with that, of course, that's wonderful, but it hides the progression that's underlying. And so no matter what we lose at the end, but we cannot see in the first 5 years neuroprotective effects. These patients are untreated, so you can run a trial for 2 years, even 3 years of exposure without getting symptomatic confounds, which is completely impossible in Parkinson's. So what drugs should we be using? I think in RBD specifically, as opposed to Parkinson's in general, it's really rather obvious what are the two targets. First of all, synuclein. They all have neurodegenerative synucleinopathy. I've showed you that. And in fact, the other thing is that they don't just get one. They get PD, DLB, and MSA. So if you can hit synuclein, you can hit all three of those targets at the same time. But the other one, I think, is the lysosome, if you want to be general, but GBA in particular. And just like I showed you, the GBA subtype is basically identical to the RBD subtype of Parkinson's disease, but they convert faster. You get both Parkinson's disease and DLB because the GBA is a risk factor for both of those. You probably will miss the MSAs, but you can screen them out pretty easily. And there's been some suggestions, should we just do GBA mutants in Parkinson's disease, or should we do everybody with, in REM-seq behavior disorder, or should we do everyone with REM-seq behavior disorder? I think we could probably do everyone with REM-seq behavior disorder based on what I told you about the clinical phenotyping. All right, so we've done a lot of work on how to do the trial. So here, you can save a consultancy fee if you're a company. Here it is. This is how to do it. Okay, so this is a generic design, and the details of which would depend entirely on which product you're using. But the critical decisions are which population. So based on these multi-center 1,400 patient trials, and based on a lot of work on doing sample sizes, my personal conclusion is I would pick idiopathic REM-seq behavior disorder, PSG proven. We have 5,000, by the way, ready to go. I would probably keep their age about 45 to prevent those really weird young, sort of possibly genetic ones. And I would do a second confirmatory test that we have something. And if you want to do an easy one, I would pick hyposmia. 2/3 of the population is eligible. MSA is gone because they have normal olfaction. And it's a very, very good correlate of synuclein seeding assays, which I didn't have time to tell you. Duration, I would do it for 2 years. I do a rolling recruitment, so that's the minimum exposure with visits every Q3 months. Make it easy on the people. That's why you can go long. The primary outcome has actually also been worked out in great detail with analysis of how every clinical marker progresses. It looks like the biomarkers don't have obvious sample size advantages. You think they would, but they don't. It's modest. So I would personally go with the clinical, and it's become quite clear that the best is a time to event analysis, categorical event, sustained clinically significant decline in either a motor or a cognitive score, or in the unlikely event that you phenoconvert without dropping one of these. These are simple. Any one of these, you hit one of these, and that counts. And no one has any trouble arguing that these are clinically meaningful outcomes, so the FDA will not give you any trouble. And again, the time to event is the analysis. Sustained, meaning you confirm it on the second visit, and when you do the power calculations, you can get them as low as 130 patients per arm if you have a 50% effective agent in a 2-year trial. So this is actually doable. We could start 3 of these tomorrow. 3. All right. So prodromal Parkinson's, a huge, fast-moving field. We have many markers. I told you about olfaction, autonomic dysfunction, motor, and imaging, which look like the best. RBD is a special case because it's not even a risk factor. It's so strong, it's basically disease-defining, and they already have biological Parkinson's disease. It marks this more malignant disease, which looks exactly like GBA, and so I think we can use the RBD model to model the disease onset. GBA, by far the most important gene in REM-seq behavior disorder, and this link between all of them, and I think is a very good target for protective trials, and we're ready to go. So with that, I'll stop. Thank you.
Thank you, Ron. Questions from the audience? While people come to, let me ask you a question. In RBD, do you have any system or any way of thinking about it as mild, severe, or it's like a dichotomous of yes or no?
It's a yes or no. The clinical symptoms don't really have anything to do with your outcome, and personally we've often found that the clinical symptoms go away when you're dementing. I've seen that a few times now. You can quantify the REM atonia. That's sort of the biomarker signature of REM sleep behavior disorder, that loss of paralysis, and that does track with time. But and it predicts outcome, but not efficiently. You can do it much better with a smell test.
And do you think there's a value in screening GBA carriers without PD for RBD to identify those that are about to convert or that are more likely to convert?
Yeah, for sure. You know, so if you have GBA and you have RBD at the same time, you're in big trouble, I would think. And yes, you have to do a polysomnogram most of the time, but to be honest, if you know what you're doing and you know what non-REM parasomnias look like, you ask a patient and you can figure out. Usually it's RBD 90% of the time if you ask the questions right, you know what you're doing.
Thank you very much. Great talk and very educational for me. I was wondering if you have any information during these long years that you are working about the imaging changes, or are you doing it only one time?
Yeah, so changes in imaging prospectively over time, most of the studies have done baseline, and there are many. So functional MRI, resting state changes. DAT scan I mentioned, 30 to 40% are positive. There have been studies showing that that is progressive over time, as would be expected. Not particularly efficient, but it certainly progresses. There are a few MRI prospective studies on neuromelanin. Nothing that's so replicable yet, I would say, but it's a very active field to study. Heidi?
Thanks, Ron. Just a obviously
sorry.
selfish. Oh,
Okay, you chair.
very quick question. So, in terms of the conversion in your trials or whenever you're monitoring, do you take it into account if they happen to get large infections like COVID or long COVID? Is there any evidence in what you can see that the acquisition of sort of an infectious disease will accelerate?
I've not seen that. I must say I got the anecdotal experience that COVID seemed to make everybody worse, but I don't think it was COVID. I think it was the inactivity associated with COVID that made everyone so depressed and inactive that they triggered their disease a little bit earlier. I informally observed that. I've not seen, infection makes everything worse, but whether it makes it worse permanently or just makes you present faster, I'm very uncertain. I've not personally seen a lot of clear triggers with infection.
But it's not something built into the trials to watch for? No.
Not particularly, no.
Just a curious question, maybe ignorant, but what about the mild biallelic GBA individuals with RBD? I don't know it. Do you know it?
Sorry, the what?
If it's a mild Gaucher?
Do Gaucher patients
If it's
have...
a spectrum or is it not? So what is there correlation?
Yeah, so again, like there's not an obvious difference between homozygotes and heterozygotes. That's sort of mystery of all the GBA metabolism. So mild versus moderate versus severe GBA mutations, do they have any evident differences? I don't think I have the power to know that, actually. Sid, did I study biallelic ones? Biallelic? You mean homozygous? Yeah, Gaucher patients. We have not, we have not seen, I haven't personally seen a Gaucher patient at all, actually, yet. Maybe that's just a coincidence. Maybe they're being followed, but I believe some people are studying Gaucher patients systematically. Yes. Yeah. Yeah, it's really something, and there's the failure for a homozygous mutation to be more than a heterozygous mutation is a mystery to me. So, as I'm sure it is to everyone in this room.
Molly Tansey, University of Florida. I think that the homozygous individual organism is highly compensated, so I'm not that surprised that homozygous don't show it and the hets do. But anyway, my question to you is I'm cheating a little because I kind of already know where you're going with one of the first trials. But the question that I have is, would you go with drugs that are getting into the brain or peripheral, seeing how the manifestations are everywhere, not just brain, like heart and gut, and why?
So it's obvious you'd rather have a brain penetrant. I mean, who are we, obviously. Now, the only, I think, maybe exception to that is if we think that the overall body is driving this, and that would have to be the anti-inflammatories, because, you know, certainly the links with inflammatory bowel disease and Parkinson's disease, and then there's maybe the vagal highway from the stomach to the brain, which is being suggested as being relevant. I think that's a little unclear, but certainly possible. Yeah, everything else, I mean, why would you ever go out of the brain? The only other one that's been talked about a little bit more is Ozempic. And so we have exenatide and lisexenatide, which have been very, very promising. I must say, I was skeptical, but that recent New England Journal is very interesting. Yep. The only problem is Ozempic doesn't cross the blood-brain barrier, where the exenatide and lisexenatide do, and the manufacturers don't make it anymore. So you just want to shoot yourself when you hear this. But you could imagine, I think, that could have metabolic changes that could affect the brain indirectly via the periphery, but I'd certainly rather get into the brain, obviously. Do RBD patients have IBD? That has not been epidemiologically studied. I certainly have 3 or 4 that I've seen, which is maybe more, I guess, than you expect in the general population. The link with inflammatory bowel disease and Parkinson's disease is sort of odds ratios around relative risk around 1.7, 1.8. So we're not going to see it with our eyes very often, but yeah.
Yeah, in relation to Ari's question about imaging, and you're noting the loss of sympathetic innervation to the heart. So can you pick up on imaging locus coeruleus changes that correspond to a drop in norepinephrine, which would then create what you...
Yes. So the locus coeruleus it's best looked at with neuromelanin scans, and it's quite obvious that idiopathic RBD patients have loss of their locus coeruleus, and it's actually probably seen in the majority of cases if you analyze it categorically. The Paris group is especially ahead of that. We've done some as well, and we've certainly seen it. In our hands, it looks intermediate to that of Parkinson's disease. You cannot link that to MIBG scintigraphy directly because all of them have MIBG scintigraphy loss. So the Japanese have actually done this, and they have 100% of their RBD patients have scintigraphy loss, and then some Belgian group, Luxembourg, I think, did one too. They're sort of 80 to 90%, and so you have a floor effect. You just can't see it. The heart's gone already by the time they have RBD, which is really interesting.
Thank you so much. Thanks, Ron.